Ladies and gentlemen, welcome to the Lake Superior QIN at Your Service Benefits of Home Health webinar. Your hostess for today is Barbara Link. Barbara, the floor is yours.
Thank you so much. Welcome, everyone. As the announcer said, I'm Barb Link, and I'm with MPRO, one of the organizations that's part of the Lake Superior Quality Innovation Network, or Lake Superior QIN. Lake Superior QIN represents Minnesota, Michigan, Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization Program. Improving the quality, safety, and value of the care patients receive through the Medicare program is what the QIO program is all about. This second webinar in our 6-webinar series highlights the innovative work that Lake Superior QIN Coordination of Care Initiative partners across care settings and in the community have done to improve transitions of care and reduce readmissions. I'd like to welcome you to this educational session at your service, Benefits of Home Health Agencies Working with their QIN. The objectives for today's session are that you will be able to define the role of the QIN QIO in the national quality improvement landscape. Actually, I can take a look at that. Discuss 3 ways the QIN QIO are supporting home health quality improvement and transitions to care at home. Identify successful strategies that home health agencies have used for working with the QIN QO to reduce readmissions. And access contact information for local QIN QOs. Because Metastar is providing continuing education credits for this presentation, we need to inform you that certificates available for nursing home administrators, social work, nursing, and are for attending this will be available at the end of this webinar. To obtain a certificate, be registered and be present for the entire webinar, complete online evaluation. No speaker or planner has any conflicts of interest to report, and there are no commercial fundings for this webinar. So before I introduce our speakers, I'd like to mention that all lines are muted during the webinar. However, after the presentation, we will have a time for questions and answers. So please make a note of any questions that may come up as you listen, or you may use the chat feature, which is on the right-hand side of your screen. So now I'd like to introduce our speakers for today's webinar. First, Donna Filer has worked in the healthcare field for over 15 years, and she's currently the Regional Director of Sales for Great Lakes Caring, and for the last 7 years, she has covered the areas of home care, palliative care, and hospice services for Great Lakes Caring. Salim Binderwala is a physical therapist by profession, and for the past 12 years has fulfilled the role of Administrator CEO of Tone Home Health Services. Salim has the privilege of overseeing a group of professionals who have led Tone Home Health to a 4.5-star rating by CMS. And apart from providing skilled home health services, Tone has also created a robust population health management model that's led to reducing hospitalization for many of its seniors and has resulted in increasing savings for accountable care organizations, or ACOs, in the area. Because of the experience and expertise of its clinicians, Tone has been recognized as an efficient partner to other acute and post-acute home care partners in the area. And our last speaker is Eric Wilson. He's the Director of Nursing and Quality at Optimal Care, Inc., which is located in Bingham Farms, Michigan. His clinical practice has included home health, behavioral health, emergency services, and wound care. Eric has a doctorate in nursing from the University of Michigan with a focus on systems, populations, and leadership. He is certified professional in home health quality, certified infection control, and credentialed by the ANCC as a Nurse Executive Advanced. Dr. Wilson currently oversees the Optimal Care clinical team and quality programs. He's actively involved in the QIN QO community collaboratives through the Southeast Michigan area, and additionally enjoys engaging in the continuing education of healthcare providers with a special focus on safety care transitions for patients into the community, infection prevention and control in the home setting, and healthcare policy and quality programs. And this just provides you a quick overview of the quality improvement organization and network region that we oversee. And here are our presenters for today. So there's Donna, Salim, and Eric in that order. And without any further ado, I'd just like to thank our presenters, Donna, Eric, and Salim, for presenting today. And Donna, if you'd like to provide an overview of the work that our Home Health Advisory Group has been doing since its inception about 2 years ago.
Sounds great. Thank you, Barb. Yes, so this group came together and was really a wonderful opportunity to bring 50 home health agencies together to really discuss how we could look at to reduce readmissions and reduce admissions and readmissions to the hospital setting and improve coordination of care and increase the community tenure. The great thing about this is when we did start collaborating as a team, we really were able to discover that all of our issues, or almost all of our issues, were very common, and as were our barriers. So we looked at setting up different ways that we could tackle these together and really look at all of the opportunities and challenges that were presented to us in a very neutral territory. There was really not marketing presented at any level. It was really just a honest collaboration of what our barriers were, and we were doing this on a basis that we could all learn from one another. When we were doing that, we were able to really look at some of the issues that we had in mind. And obviously, we looked at the readmissions as one we were definitely working on. And there's been other issues that have come up, too. We had the pre-screening process, which was one of our first initiatives we worked on together. And Eric will speak a little bit more about these in detail. The CHF initiative that we had. And overall, we did get involved in the very beginning on really working with how we were going to collaborate with our hospital partners and provide them an educational outlet to really understand what we need and how we could collaborate better with our hospital discharges, regardless of any home care company that was being used. So that was really what we called our community tenure project, and we really had a presentation put together in a CE format, and we went out to the various hospital organizations and put together our presentation. And really that presentation highlighted what home health is, how we operate, and the information that we need, and some of the barriers that we have in bringing some of the patients on board. It was a very educational opportunity to have a great collaboration with our hospitals and also all the home health agencies to see that we were one team working together to really improve patient care. So with that, I guess, Eric, I'll give you the opportunity to look at some of the other initiatives we worked on. I think I mentioned the CHF was one that we worked on, and then also sepsis is the newest one we've also begun tackling. So, Eric?
Thank you, Donna. I think I just want to piggyback a little bit on what Donna had talked about with the Operation Community Tenure project that we focused on with the different hospitals, and as well that it came throughout the Southeast Michigan Collaborative, where kind of everybody comes together to discuss what's going on. I think what we had learned early on as we shared some of the barriers, really in the beginning it was a lot of barriers, to determine where we needed to focus our efforts for those patients coming into the community, and how we can improve the overall outcomes for that. And so with the Operation Community Tenure, we were able to really provide that meaningful insight into discharge, bringing to the table real examples of patients, what they come home, what a home med reconciliation looks like, what we need from the discharging hospitals in efforts to ensure that there's a physician following for the plan of care or things like that. And I think over the past 3 years, so it's in April it'll be 3 years since we initiated this community tenure. What we have seen is our QIN, QIO has really served as a conduit into the discharging acute care facilities, the hospitals, and we've really seen some changes being made on multiple levels. And one of the, actually, Barbara, if you could just advance forward to the, yeah, I know we're going a little out of track here, but that's okay. I think one of the things that these were the learner outcomes that we had put into place as we started this. And I think what we have seen over the past 3 years with the different health systems and the partnerships with home health, that these have kind of been brought to the forefront for the different collaboratives that we've even taken to the table with some of the health systems. So really measuring out that safe, coordinated care. And we're starting to see, I can tell you just from experience and from talking with some peers in the home health community, we've gotten overwhelming support from the acute care facilities, from the hospitals, and I really credit the QIO and the QIN for helping push that and getting us to the table. We're seeing much better transitions of care as far as information exchange, so patient diagnosis, ensuring that the primary physician, is listed on the discharge paperwork or even being contacted before the patient's discharged, knowing that they're coming home with home care, so that it's not a surprise to the doctor when the agency is starting to, develop that plan of care to ensure the patient stays safely in the community. Even we're seeing on the discharge side with plan of care is already being kind of set up, and more education materials, so that when the nurse arrives to the home or the therapist arrives to the home, that they've got written educational materials ready to go from the health system already, so that you can really just start to dive into that patient care right at visit one, and you're kind of eliminating all that extra work or wait time to get your materials into place. And we continue, I know, between Donna and Great Lakes and Tone and Optimal Care and many of the agencies out there, meet with the hospitals on a regular basis to share some of these barriers that we're still coming across, but also we've gotten to share a lot more successes because we've been able, to use, to work together through the quality community here in the Southeast Michigan area to really bring more success for the patients. And I think we saw that in some of our home health readmission data over time. I think that's the previous slide. Yep. In 2017, as this took off and we started to really, from 14 to 17, to really start to measure and look, and we can see the general decrease over time. It's always multifactorial, many variables, but it's nice to see as you're putting, things like Operation Community Tenure in place, you start to see this general trend downward. You start to see, raise more awareness. You start to have these partnerships that are not just generated from the agency side or the hospital side, but they're also coming from the CMS side, because we know, as the QIN code really represents, the Centers for Medicare and Medicaid, to ensure that we're up there providing the highest quality of care possible, to keep patients in their home, to keep them safe and keep them well. So I think this community collaborative, this specific project really spoke well to not only the home care community of what sharing can do and what a neutral territory can bring, but it also helped push forward the other initiatives that we're, kind of progressing forward with now, working on. I think Celine's going to go ahead and kind of introduce those and also jump into what really got us going was, as when our first meeting, we had to systematically sit down and decide, what's the most important thing right now on the forefront. And at that time, it was split pre-claim review, which we know kind of went away, but we have review choice demonstration coming. And so we're already so far ahead as a community, as a collaboration, in that review choice demonstration as that approaches, because of the work we did early on, the preparation we did early on, and how, we keep talking about it and keep bringing up. So I'm going to hand it over to Celine to talk about, where we are and where we're going, and I think I'll take it back to dive into some of our more projects.
Thank you, Eric, and good afternoon, everyone, and thank you for joining in today. since Eric and Donna did not leave much for me, but I'll still try to talk about the other tangible benefits of joining a MPRO Home Health Agency work group. All states have their home health associations. We do. We have the Michigan Home Health Association. These associations usually discuss the policies and the government changes coming in the industry. MPRO, under the guidance of Ms. Barbara Link and her team, gave us an opportunity for our local home health community to get together to solve everyday problems. And these everyday problems range from the ADR issues in our area to improving care delivery processes to promoting home health awareness in the community hospitals to emergency management planning. So all the new and upcoming changes with Medicare, we were discussing in real time and learning from each other. Benefits of sharing best practices in the group helped all members, irrespective of their size, to do a thorough introspection in their own care delivery process and give their opinions to the group. Here we saw each other as peers rather than competitors. This was a major change from what we had always been doing in the past, and that is to see our colleagues in the area just simply as competitors. As a home health agency, we all have a crucial objective to meet, and that is keeping our patients out of the hospital and safe at home. While some of the agencies in the group had developed a good process around medication reconciliation, some other agencies had ideas about real-time HIPAA-compliant messaging software. And some other agencies had their best practices or protocols for their CHF, COPD, and pneumonia patients. Sharing these ideas amongst each other helped every member of the group. Sometimes these discussions were during the meeting and sometimes one-on-one basis after the meeting. Irrespective, this is a fabulous opportunity provided by our QIN. Yes, we do have Facebook home health groups and LinkedIn groups, and we at times do reach out to them for suggestions. But in these meetings, we are all agencies in the same local area, so we know our patient population better. The suggestions and recommendations that came out were thus more likely to be effective in the patient care processes. Folks, as an industry, we are all aware that the healthcare landscape is changing. Review Choice Demonstration Program, RCD. Patient-driven payment model coming up for the nursing homes starting in October 1, 2019. And then, yes, patient-driven grouping model for PDGM for the home health agencies, which begins January 1, 2020. These are significant changes that are going to hit our industry in a very, very short span of time. One can tackle these issues alone if they must, but these daunting challenges can be a lot easier to tackle if we all put our minds together. I'm pretty sure that in the coming up MPRO Home Health Committee work group meetings, PDGM is going to be discussed a whole lot. And we are all going to use these discussions and put best practices in our company to not only survive but thrive in the PDGM era. The one key requirement for coming to these meetings is to bring an open mind that is ready to learn and ready to share. Although there are lots of benefits of coming to a home health agency work group, I am going to give you some few tangible ones that I personally thought helped me a lot. Number one, learning evidence-based best practices, both in clinical and office practices, that can help you become a lean agency. At Tone, I have made several changes in the workflow process at my office after coming back from these meetings. With the increasing demands on regulation and an ever-decreasing reimbursement, it is imperative that all agencies have and follow a lean management process in order to be more efficient and effective and have better patient outcomes. Number two, learning about upcoming webinars and seminars in your area that can really help improve your skills as an agency. Number three, receive latest news in the home health industry, both regional and national, about the changes coming up in the industry and give you a heads up to prepare your agency for it in advance. Number four, that is my favorite, is the survey experiences. All agencies have surveys coming in or they are preparing for one. discuss survey experience in the local region which can help everyone to be better prepared. This was truly one of the most important aspects of these meetings. All agencies have questions pertaining to their Medicare guidelines at times, and you always get answers from one of the participants in the group. Number 5, creating a customized educational resource for all referral sources so that all agencies are speaking one language when it comes to spreading news of upcoming changes with Medicare to all their physicians and other referral sources. To give an example of this last one, let me take you back to the pre-claim review era, PCR. I sincerely apologize to any agencies from Illinois to make them remember of that time period again. But Michigan was one of the states to follow after Illinois. Our home health work group worked diligently for a few months to create a one-page educational resource to notify physicians about the upcoming changes with the PCR. This way, a group of home health agencies in the local area, along with the help of EMPRO, distributed educational material to a wider group of physicians and other referral sources. This would never be possible as a standalone agency. Our EMPRO Home Health Quality Work Group has reached out to other industry leaders at times when there was need for it. We reached out to HHQI, I'm sure everyone knows about them, the Home Health Quality Improvement Group, at times for sharing their resources and their expertise. We reached out to Visiting Services of New York when we worked on our early sepsis identification program. Being a part of the larger group gives access to a variety of leaders in various healthcare fields. After all, why spend time reinventing the wheel? Now, I also want to take opportunity to wish the very best of luck to all my colleagues in home health. We have some drastic changes coming up in the industry. As if new COPs, the new emergency management requirement, OSSD, QAPI, as if they were not enough, we now must prepare for Review Choice Demonstration Program, RCD, and Patient-Driven Grouping Model Program, PDGM. To end my part of this session, I would just simply say, alone you can go fast, but together we can go far. Thank you, EMPRO, Ms. Barbara and team, for creating these groups to improve the quality of care in our home health industry. And thank you for everyone for your time this afternoon. I hand it over back to Eric to speak a little bit about sepsis program that we created along with the Visiting Service of New York.
Thank you, Celine. Don't think much more to be said about that. I mean, it really gave a great kind of overview of what we do and how we come together as a group, and what we're to expect down the road. Really awesome. So on here you can see some of the things that we have been focusing on. I know I dove deeply into the community tenure, which was, much more of a, I would say, qualitative project overall on how we worked with EMPRO. But now we're really starting to get into, and those of you who are on the call in the home health industry and the QAPI, really starting to dive into those things that are systematically focused on not only in the conditions of participation, but just Medicare as a whole, and diving down into sepsis and heart failure and care coordination conditions and things like that. I think, before we started diving in some of these bigger projects, we first took on what we thought would be one of the more concerning areas as patients come from the inpatient side into home health, and that was the timeliness of care. Why were we seeing the barriers, and why were we seeing the successes? So we were able to, with the help of EMPRO and submitting data and analyzing that data, we were able to we did like a 2-week trial of looking at our patients that came into home health from the inpatient side, whether it was from the SNF or rehab or hospital, and to assess why those particular patients were not getting seen within the first 2 days of discharge. I think this was a good opening point for the group, kind of like that icebreaker point, because it is a publicly reported measure. It's something that we find that we can struggle with at times because we don't have the appropriate things, and that's a lot of times what it was a demographic error for address, or we don't have a physician to follow for care, and so we're able to take those mini projects within the group to start to come up with different interventions or different strategies to ensure that these patients get seen for the timeliness of care. And at the same time, the agencies get the benefit on the back end of improving their own quality metric or STAR metric related to timeliness of care. And so, again, looking at the group as a whole and going forward like that, sharing, learning those barriers and figuring out how we can be more successful, I think really ignited us as we moved into this new era of, well, I shouldn't say it's a new era of sepsis, but as sepsis is coming, sepsis early recognition is now coming into the home health sector. Barb, can you just advance forward to the sepsis training slide? So this is actually even more far spread than just the home health, and I think this is where that partnership with MPRO comes into key play, because it really brings together every setting for this specific diagnosis or condition that's concerning to the Medicare population or the population as a whole. As we know, what was kind of, as a group, what was kind of interesting to us is there was this initiative going on within the health systems and the SNFs with the sepsis early recognition and treatment programs, but when we look at the statistics, 80% of sepsis is occurring in the community, and we as agencies weren't really taking the initiatives. I'm not speaking for everyone, but as a group, I could say we weren't really taking the initiatives for early recognition, standardization of early recognition in the community. And at the same time, we weren't really being brought to the table for this, and so this is something we kind of pushed. And secondly, this is the second leading readmission diagnosis in the state of Michigan, so it's very applicable to admissions and readmissions and high-risk patients associated with your home care program, whether you're looking at it from sepsis or whether you're looking at it from infection. Is it urosepsis? Did it originate in the respiratory system or things like that? So it was really an opportunity to now not only bring forward a high-risk, costly diagnosis and problem to the home health agencies, but also to really work together to develop a plan to improve the care of these patients in the community and ultimately, hopefully, prevent a sepsis from occurring. And so I think as we started to dive into this, so we were able to partner closely, and we still are. So we've only done a pilot group, and now we're in the very, very early stages of our first agency rollout for the sepsis training. But one thing that was way different about this program compared to what the hospitals and the SNFs were doing is the patient that you're treating. So in home health, we don't see the patients every day, right? In home health, we don't want the patients going back to the hospital. We don't want them to get a worsening infection or sepsis. And so a key component of this was that patient caregiver self-management tool. How are we, do we have the right tools out there to educate patients and caregivers to self-assess for signs and symptoms of sepsis? Do we have the right home care tools out there for patients and caregivers to prevent an infection from occurring or a worsening infection? And are they standardized and evidence-based? So we were able to work collaboratively with Pat Poza out of St. Joe's Ann Arbor or the Trinity system, and just learning from the Tri-County SNF Collaborative how we are going to roll this out into the home health. But it also has a huge benefit because it can be wrapped into a very strong and fulfilling QAPI initiative for the agencies, because it has a robust focus on improving patient outcomes, focused on admissions and readmissions. It has a robust focus on infection prevention and control, on monitoring your processes, on internally auditing your current protocols. Are they evidence-based? Are they up to standards? And gathering all of these people and all of the information in the groups and the meetings and organizing everything from the minor details of what presentation one's going to look like at this hour, at this minute, what videos we're going to show. You can't do it without that huge support, that backing support from MPRO. Just bringing multitude of agencies, facilities together to be able to develop something like this and roll it out. And this is a huge opportunity just for the state of Michigan, for the Southeast, to really standardize a process across all provider entities, to really look at how we're using service criteria in the community versus the SNF versus the hospital, but using a standard language. So when the nurse presents in the home to the patient and sends the patient out because they meet, service criteria or are actively septic, they know the key reporting that they can give to the ER, so that the ER knows when that patient shows up, I've got to get blood cultures and I've got to get labs, I've got to start IV antibiotics and fluid within X amount of time, because as we know with sepsis, timing is everything as far as administration of IV antibiotics and fluids. So that's really key, and you really credit your QIO and working with them in organizing these things and helping to get the buy-in from the hospitals, from agency leadership, and from skilled nursing what was going through the same thing. So it's really exciting time point in home health for Southeast Michigan. As we exciting and scary, as Selena had mentioned. As we are really starting to dive into stronger quality initiatives to improve and being held accountable for that. And I think that's the key, is we're all being held accountable, and we all want what's best, for our community members as far as the treatment. I think MPRO really helps promote that. And as Celine said, we'll be working really hard as we move forward, coming up with strategies to improve agency outcomes with PDGM and the review choice demonstration. So
backing on Mr. Eric, I think he hit the nail. A few years ago, if you look at home health, most of the agencies, all they had to do was get luncheons to a doctor's office, and they would have referrals in their offices. That has completely stopped years ago, at least a couple years ago. Now we have moved from from fee for service to pay for performance. So it's all down to the quality of the service that we provide. Before you even get, at least I can talk about my agency, before you even come to a doctor's office, or they already have my numbers in front of them. Either somebody in their office has pulled up my home health compare data or things like that. So in this era, to even survive as a home health agency, we all know how important it is to have our numbers be in the right zone. And for that, you have to have best practices in your offices. And there is no better way than to learn from the best in the community, get to them, get together with them. And I think MPRO is giving us the opportunity to learn from the best practices of each other. And as I said, previously we were all competitors, and now we are seeing each other as peers, and that that will help us go through a challenging time as PDGM. Folks, I cannot emphasize the importance of preparing it for it now. I think even somebody thinks starting in October or November that they will start preparing for PDGM, it might already be too late for them to start preparing at that time. So I highly encourage everyone to see if they can reach out to their people like Ms. Barbara and start joining these home health work groups to learn and be more prepared for the upcoming changes. For us, again, I'm saying, like, and this is what I tell all my staff, that you are not a physical therapist, you are not an occupational therapist or a registered nurse in a home health field anymore. We are all simply agents for preventing hospitalization. That is how important this concept is, that if you cannot bring your hospitalization number down, you will not be able to survive in this market. And for that, we have to implement best practices, like how Eric said. We have to have out-of-the-box thinking about how to not just look for, prevent sepsis before it comes to a point. Yes, the patients do end up in the hospital, and yes, they will end up in the hospital even after we do the assessment. But maybe we can get them there before it becomes severe enough to get them in ICU stay. So that was the point behind that, like these work groups, we have been diligently working on things that are upcoming in the industry so that we all are better prepared as a group and we can educate our physicians and other referral sources in a timely manner so that they don't end up giving us a hard time about it. Ms. Barb?
Well, I want to thank everyone for their presentation today. Did any of the three presenters have anything else that they wanted to talk about regarding the group?
Well, I think just to piggyback on what's coming for the home health as far as, we've been working on the sepsis, and now we'll start to look at the heart failure initiatives and the toolkits. We've done some work already in that arena, working on a kind of a one-page educational sheet. Again, standardizing that education across agencies for what they can use for good heart health for the patients. And I think that's our first step in that direction. But now, again, kind of similar to what the sepsis program will look like, but how are we approaching the care of these patients with heart failure? It's still a tough population to manage in the home, especially when it comes down to the chronic condition and the chronic nature of heart failure and the comorbids that come along with it. So, for future of what we're looking into, like Celine had mentioned, the sharing of the PDGM, the heart failure toolkit, and thought we'll do another sepsis in the summer, I believe. Barb, you can correct me if I'm wrong on that.
That's correct.
Yeah. And just, again, continuing with that care coordination network throughout, like conduit of the Southeast Michigan Collaborative.
A whole lot of discussion in these meetings that we had with the home health agencies. Obviously, we can all imagine the main discussion was what are the top things that an agency can do to prevent hospitalization. We had a lot of conversation, but putting a few things in the top of the mind is one of the things we can make another short list, as I can say, is making sure that the patient gets back to the doctor's office within the first 5 days of coming out of the hospital or nursing home is probably the number one thing that a home health agency can assist in bringing them down their rehospitalization numbers. Almost 66% of the hospitalizations are reduced just by making sure that the patient gets to see their primary care physician in the first 5 to 7 days out of coming out of the hospital. The second thing that tops in our process of reducing hospitalization is a thorough medication reconciliation process, making sure that the patient is not taking any excessive medication than they are supposed to, that they are taking exactly what they are prescribed. I think of the medication reconciliation process as a two-step process. One, when they are coming out of the hospital, to make sure they are taking all the medications that the hospital has prescribed, but more importantly, to get the same patient back to the doctor's office so that they can see their PCP who has been seeing their patients for 15 to 20 years, and then again do a step 2 of the medication reconciliation when the patient comes back from the doctor's office. So, like, making sure patient gets to the doctor's office. Second step would be medication reconciliation. Again, front-loading your visits is always important, not only from the nursing standpoint, but also from therapy to prevent falls. Another one that we kind of skip at times, I'm not talking for everyone, but the importance of the social worker in order to prevent hospitalization. So these are all the topics that we have been regularly discussing in these home health agency work groups that really helps agencies on a process level to reduce their readmission numbers, to get back on track with getting the numbers back where they need to be for an agency. As I mentioned earlier, it is no more luncheons at the doctor's office. It's all about our numbers on the home health compare data.
And I think Medicare's kept to piggyback on the med reconciliation. Medicare's really caught on to the importance of that, and I think you see that in the PDGM with the MMTA type of episode of care, the medication management, teaching, and assessment. And so, a lot of things of what you really want to consider is a robust. Those things that don't occur during that first visit but are assessed are really the key things that can keep this patient out of the hospital, so that hospital discharge to home, so ensuring that the patient has the correct med list and the correct meds from that hospital discharge to home. And then, like you said, Salim, coordinating that visit to the physician, ensuring that the patient gets their meds from the pharmacy. These are all things that are coordination related that are technically kind of outside of that visit, that scope of education and training, but still have to take place and really are part of that case management aspect that we use in home care. And CMS with PDGM is really going to start holding people accountable for that and coming up with the strong interventions and being creative in how you're providing care to these patients to ensure that their needs are being met. And a lot of it is that care coordination aspect within that first 7 days and that discharge. So I think those are really good examples.
Right. And some of the important things that we already have discussed in our home health agency work group regarding the PDGM process is I cannot emphasize the importance of having a thorough referral early on before we even get to the start of the care, to have all the required documents in hand so that your coding and everything falls in place, because as everyone knows that the episode is going to be a 30-day episode instead of a 60-day episode, we need to be twice as fast as what we already have been used to. Another thing that I can think about in PDGM that we have already discussed is the importance of educating our physicians for the timeliness of signing our documents. And I am pretty sure many of you might have chuckled when I did mention about timeliness of physicians signing the orders. But yes, if they do not improve their habits, we might have to bear the brunt of it. So that another thing that we have to reach out to our physicians, and I'm pretty sure Empro would help us, get this education out to them to assist us in surviving this another phase of home health. And I believe that this PDGM is not like a change of OSs and a new OSs came in and now OSSD came in. I think this is a big change, and it can take down agencies if they are not better prepared for it. So that importance, again, coming back to sitting down as a local community together will help immensely for all agencies who are looking to come out successive in this era.
Well, thank you all very much. This is Barb Link again, and yes, I've been a part of the home health work group since its beginning. I think some of the things, just in summary, to sort of circle back on all of the things that Donna, Salim, and Eric have talked about today, the ability for the group to trust one another, and in a very competitive industry that the group members have come together as home health agencies and realized that, the sum of the parts is not as, what is that saying, as good as the whole of all of us, that really the exchange of information and education, that the things they're struggling with and someone's found out a process that has worked for their agency and how it's been able to be replicated at other agencies, sharing of best practices, using data to drive some of the decision making, having the ability for the QIO to be the neutral partner, to be present, to establish sort of boundaries and rules for the group so everyone is participating equally and feeling that it's a safe place to exchange information and work towards improving care of all the patients in the community, I think has really been something that has driven this group over time and been able to provide the wonderful tools that have come out of the group, as well as some of the trainings and education, and to see that really their efforts have really worked in the Southeast Michigan community to drive readmission rates down for the Medicare fee-for-service population. So I've just been honored to be a member of this group and truly believe that this is a collaborative group that really sees the greater good of the patients that they care for and want to have patients stay in the community for as long as possible. So again, I just really think that this is a wonderful representation of the group members through Donna, Salim, and Eric. I truly appreciate their time today and their ability to present all of the aspects of the home health care work group, as well as how MPRO as the quality innovation organization has been able to support them through their work. At this point, we now have time for questions or comments for our speakers. So, operator, will you please remind our participants how to get in the queue for questions or comments? And also, people can also write anything that they have as a question in the chat box as well.
Yes, absolutely. Ladies and gentlemen, at this time, if you have any questions, please dial the *1 on your telephone keypad. Again, that's *1 on your telephone keypad. And we do have a question from Janelle Shearer. Janelle, the floor is yours.
Hi, Barb and everybody. Thank you so much for that great presentation. I love how you brought 50 home health agencies together to work together. I have a question about the presentations at the hospital level, because I know that's a challenge, especially if you are not a hospital-based agency. It's hard to get to the ears of the people. So I understood that you went as a collaborative, or you were representing a collaborative. I'm just curious, like, how did you get to the hospital folks, and who did you, just some more logistics on how you got to them, what kind of people you met with, how it went, that type of thing. Thank you.
Okay, Jen, this is Donna Filer. I can probably speak most to this because it's probably one I got most involved with, this collaborative initiative. What we did is the hospital, one of the largest hospital systems in Metro Detroit, we personally at Great Lake Caring had a very tight relationship with them, but understanding that overall I felt that they needed some education with their case management team, we went as a team and really presented to them that we'd like to bring in a CEU and really discuss just overall care collaboration and continuing the patient care out in the community. And they were actually really overwhelmingly excited to hear from all of our agencies as one. So I think sometimes it just really involves one person in your collaborative who's willing to take the chance and really, I guess in other words, exposing their referral sources to the greater good. And in this case, it worked out wonderfully because it was a really great effort for them. I think they were overwhelmingly surprised that we all stood up there as a team and just talked about different issues we all had, and really came as a united front. So I thought it was really a great initiative. And then we went to other large healthcare agencies in the community and presented to the case management team. So that's initially where we started. I personally have a large initiative, which I would love to get to the hospitalists and the doctors group. We haven't yet had the opportunity to do that. That's a little harder group to get involved with. But we were able to get with the case management, and I think that's the start. At least I felt good about that. Anybody else that want to comment on that?
Well, I think when you put MPRO's name behind it as well, it pushes it forward faster because, MPRO's job is, don't mean to speak for them like that, but they, they are the contracted service to promote quality improvement throughout throughout Michigan for our region. Now it's Lake Superior, But hospitals in our area specifically really respect that, and a lot more open arms once you kind of got that backing from your QIN or QIO.
Thank you. Well, it's just awesome that you guys could do that.
And at this time, there are no other questions in queue, but as a reminder, the star 1 on your telephone keypad.
Okay. Well, if there are no other questions at this time, we will conclude this portion of the program. This includes this educational session. I just wanted to thank Donna, Salim, and Eric for speaking with us today. They truly are dedicated partners and really believe in the philosophy of true partnership and increasing the care for patients in the community, and I think that came through with their presentation today as well. The next webinar in this Success Story series is using data to drive community quality improvement efforts, and that will take place on March 26th from 11 o'clock to 12 o'clock noon Central Time and noon to 1 o'clock Eastern Time. So before you close out today, please complete the survey. It will pop up, so you have to actually close out of the presentation, and then the survey will automatically pop up in your browser. And we have put the link to that in the chat box. No, that's not. It'll just pop up automatically, and then you can complete that. Once you've completed that, then you will then get I believe a link in your email that will then provide you the certificate for today's presentation. So we appreciate your feedback on today's session. Once you've completed that evaluation, that's when you will receive a certificate of completion via email. I believe that's what I just said, but now I see it here. Please make sure that everyone on your team that wants a certificate completes the evaluation, and the session was recorded and will be available on the Lake Superior QIN in about 2 weeks if you would like to review it again. Thank you all for participating, and have a great afternoon. Thank you.
Thank you.
Thank you, everyone.